Glaucoma filtering surgery is the most effective way to control the intraocular pressure in the eyes that are no longer responsive to medications or if the medications have systemic contraindications to the patient. Preparing the patient for glaucoma surgery includes the following steps. Number 1. Number 2. After the patient has been properly prepped and draped, the following steps are taken. The lid retractors are applied, making sure that there is adequate exposure of the globe superiorly for dissection of the conjunctiva. Vicryl 6-0 spatulated sutures are passed through the cornea and act as traction sutures. Traction is applied in such a way that the superior nasal part of the eye is exposed. Subconjunctival injection of a mixture of lidocaine, epinephrine, and mitomycin is placed in the surgical site. This will allow adequate hemostasis and soak the tenons in mitomycin for the duration of the surgery. Fornix-based peritomy is performed at the limbus for approximately 3 clock hours, favoring the nasal side. Hemostasis is achieved using a cautery probe. It is important that bleeding is controlled to achieve a high success rate. The flap is fashioned using a blade 15 scalpel, incising at half depth. The flap is lifted and peeled up more than incised to allow it to follow the tissue plane. The blade 15 scalpel is used to tunnel into the corneal stroma, taking care not to enter into the anterior chamber. Paracentesis using a 15-degree knife to create a side port is performed to allow for infusion of fluid in the AC. A 2.75 keratome knife is used to enter the AC beyond the flap and widen to approximately 4 mm. A blade 11 scalpel is used to make an incision at the limbus, taking care not to injure the underlying iris. The corneoscleral block is then excised. A peripheral iridectomy is performed. This should be wide-based and if properly performed, should allow the rest of the iris to fall back into the anterior chamber with the triangular iridectomy. Fluid is infused via the side port and fluid should exit the filter site without iris prolapse. The flap is closed using a nylon 10-0 suture. Fluid is once again infused via the side port, and fluid should exit without impedance under the flap. Antibiotic and steroid eye drops are mainstay post-operative medications and are maintained for 2 weeks. All anti-glaucoma medications are hence discontinued for that eye. The pressure of the eye should range between 5 to 10 mm Hg after surgery. Close follow-up to ensure continuous filtration is necessary.